This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'm joined by Dr. Jean-Philippe Deneuville for a conversation about disc mechanics, directional preference, and diagnosis. We discuss key findings from studies on disc behavior under load and the dynamic disc model, insights from quantitative MRI research on nucleus pulposus changes with sagittal bending and radial fissures, a new numerical algorithm developed to detect centralization and directional preference, the use of digital body charts and control discography in assessing spinal pain, and more. Dr. Deneuville is a French physiotherapist specializing in musculoskeletal disorders. He holds an International MDT Diploma, a Master's in Musculoskeletal Physiotherapy from the University of Dundee, and a Ph.D. in Mechanical Bioengineering. A McKenzie Institute faculty member since 2017, he has taught over 100 courses worldwide. His research focuses on intervertebral disc disorders and spinal pain, working closely with the PRISMATICS team to develop new diagnostic and treatment technologies. He currently balances clinical practice, teaching, and research. If you find our conversation informative, don't forget to subscribe, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from these insights. Thanks for tuning in, and now let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi, Jean-Philippe. Welcome to PT Pro Talk. How are you today?
Fine, and you? Thank you for inviting me.
Awesome, I'm good, and I'm excited to our discussion today. So let's just get started talking a little bit about yourself and your background.
Okay, so I'm a physiotherapist. I'm French physiotherapist, as you could hear from my accent. I've been graduated. I graduated in 2008, and so I practiced since that time. So 17 years now. Oh, it's long. And I have my I got my MDT diploma in 2014, and I'm French faculty for the French branch since 2017. I also have a MSc in science and a PhD that I defend 4 years ago in 2021. And my PhD was on disc pathology and how to characterize patient and other more fundamental aspects of disc pathology.
Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sarah Health. Visit sarahealth.com/ptprotalk for a 90-day free trial. That's sarahealth.com/ptprotalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/ptprotalk. And now let's get back to our conversation. Okay, so we have a lot of different topics to discuss today, so let's see what we can get covered. So I was reading your paper that you published, I think it's 2021, right? The one about the MRI study. Do you want to just give us like an overview of that study? It sounds really complex, so maybe it's easier if you just briefly tell us about it.
Okay, so the story of this paper. I start my PhD. Before my PhD, I wanted to do. When I was discussing with PhD school, I wanted to do a very clinical based PhD on the way with directional preference we could prevent surgery among patients with disc herniation. So it was very clinical focused. I tried during 2 years to get a grant, so I didn't have it. And my future PhD mentor, which is a neurosurgeon, say me, in medicine, it's not we are not working like this. It's not it's not by doing clinics first. You have to first do some fundamental science to demonstrate that your approach has some value on the fundamental side of the the problem. So, for example, when you want to do a clinical trial with medicines, you have to demonstrate that you have a biological effect. So he said to me, you want to use exercise, so you have to demonstrate that your exercise have an effect on the disc. So start by doing PhD in biomechanics. And when you will have some good hypotheses which are well defined by biomechanics data, it will be much easier to get some big grants to do more clinical research. So I say, I was not very happy with this, but I say, okay, let's do it. And I'm very happy that he pushed me to do this, because now I have no regrets. It was very fine. And so my PhD, my main hypothesis of my PhD, and it is related to this paper, was I wanted to assess if the hypothesis of McKenzie was true or false. By this, I mean, when we have a directional preference, are we moving the nucleus pulposus into the radial fissure or not when we have a patient? So I wanted to, so the first steps to do this, is to develop the tool. No, first step is to review all the tools that we have in the literature to see if we have something which is able to assess this. And this is a paper of 2025, which was out after the first one, but it's a systematic review in which we review all the study on MRIs that have been done on the disc, and we found no MRI sequence or MRI tool or any tools that can assess that aspect. By this, I mean, when we have a fissure into the disc, are we able to see the nucleus moving in or out the fissure? So I had to develop this tool. So I did. I start a collaboration with two research laboratories. One is a biomechanics laboratory based in Poitiers, and where I did my PhD. And the second one was in Switzerland. It was with physician of the MRI, not physician like doctor, but physician like who study physics, all the theoretical part of the MRI. So I start the collaboration with these two teams, and I came there and I say, okay, here is what I want to do. I want to see first, how can we create an MRI sequence that able to see if we have a fissure into the disc or not, because for now we don't have. And second one, I want to see if we are moving the patient in different position or different way. Are we able to see if the nucleus is moving in or out the fissure? They say, well, fine, let's start. And so we start with very first steps of the process. So we use some cadaveric piece of sheep, and so disc of sheep, and we put them into the MRI. So it was very funny. We had the MRI for 3 days. So the 2 million euros tool engine, and we put some piece of sheep in it. So it was very very fun. And we put the vertebra in different kind of different position, etc., just to have an idea in which way we could improve the sequence to see better what there is into the disc. And then we do a second round of experimentation in which we put the we set up our hypothesis, and we test a protocol in which we had a sheep disc in which we put in flexion, extension, and neutral, and then we do a fissure and we redo all the experimentation, and we could see that the nucleus is moving in and out the fissure. So the main goal of the experiment was to see this, to see if we are able to see this. So we were able to see this on a cadaveric sheep. So it was nice. And then the next step would have been to progress to human cadaver, and then to human. And unfortunately, the COVID starts, and so end of all the experimentation.
Oh no!
And yes, and my PhD is now finished. I continue to do some. I try to maintain this collaboration, but it's difficult. But but very recently, I joined another university team, and I will probably
Continue.
restart. Yes, continue, but there is a 4-year gap between the first and the second experiment, so it's a bit frustrating. And so this is not classical MRI sequence. It's very specific MRI sequence. And next step would be to adapt this to human, and then to put lots of patients into the MRI before and after MDT assessment to see if we have any change into the disc morphology.
Yeah. And on this next stage that you're planning potentially, do you think you would be able to do with humans?
Yeah,
Is that the
yeah.
goal?
It's
Yeah. Yeah.
it's a goal. There will be, I think, lots of steps before, because there is lots of when you start, I had absolutely no idea of what is an MRI, and now I know. And all the issue, very very basic one, which is very very well, you don't think of it when you are planning the session, but there is the aorta just near the spine, and with the kind of sequence that we are using, we should have no movement, and the aorta is moving a bit, and it creates some artifacts. So just that kind of stuff, we need to do lots of experimentation and test retest before to have a sequence that we could use with a patient. I think it's at least a 5 years work by doing, redoing, etc., before to have a sequence that could be able to scan patient in a prospective way to assess the hypothesis. So this is
Mm-hmm.
nice. It's cool.
Yeah. It sounds really complex to be able to get that accomplished.
Yes, but there is, I'm not doing this. I have the idea. I know where I want to go, but there is lots of background with technician and researchers that are specialized in this, in how to parameter the MRI, how to analyze the figures that we get, etc., etc. It's a team research. It's a teamwork.
Mm-hmm. Yeah, yeah. Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. And like from that first paper, could you draw any conclusions on like I saw that you tested inflection extension, right? To see the nucleus moving. Did you get any conclusion of like directions and things, or was just to kind of see it moving? Or like and I know it's like an animal, so it's really hard to compare, but
Yeah, it's a very 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 low level of evidence, because it's only one specimen, it's animal and it's cadaver, so it's three elements that lower down the evidence. But from this specimen, it moved perfectly as expected. So when you have we did an anterior tear because it was easier to do on the disc. And when you do flexion, the nucleus is moving out of the tear. When you do extension, the nucleus is moving into the tear, and it was replicable, and it was like expected. But as I say, it's only one specimen, cadaver, and chip. So there is a need to replicate and to work on it.
okay. And how about that systematic review that you did, that you just published? So any conclusions from that? Anything that is relevant that you think you would like to share?
Oh, yes, I think the conclusion is at first look, it is very it's a bit frustrating, because the conclusion is there is no evidence regarding the disc model, either if it's wrong or right. So we still don't know. And for LC disc, for people who don't have any pathology or pain, it's worked really well. Flexion makes the nucleus moving backward, extension frontward, lateral bending onto the left, the nucleus go onto the right, and it's pretty consistent across the spine. So it's worked pretty well for the cervical spine too. So this is for the LC disc. But this is an important step, because if it, if the model doesn't work for LC disc, we will not test it for pathological disc. So the first step is now validate, and now we can go to the pathological one. And for pathological disc, there is no study that assess properly with right tool and well established hypothesis the disc model. So the conclusion is we don't know.
Mm-hmm. And that's what you're gonna try. That's your goal next.
Yes, we need to develop we need to develop the tool to assess this, and then test it with patient and with a cohort of patient in clinical condition.
Mm-hmm. Yeah, very good. And then I remember that from one, I think maybe both studies, people did in the past some discography, right? But it was very invasive, and that's why you were trying to find other ways to do with MRIs. Is that right?
Yeah, there is two problem with discography. Discography is very fine to identify a painful disc with a patient. So if you want to know if this patient have a L4A5 or L5S1 painful disc, you do the discography, you will know it. But it is invasive, it is very painful, there is some side effects, etc., etc. So you could not do this for every patient. So there is a need to non-invasive procedure to identify painful disc. And the second limitation of discography is you only know that the disc is painful, and you have some clue about the fissure in it, but you don't know if there is some nucleus which is moving in and out. You don't know if there is any change in biological aspects, because it is one part of the it is one side of the disc pathology, etc., etc. It's a nice tool, but it's limited. And the second side of the research that I am doing on MRI uh, is to develop clinical tools that surgeon could use to identify painful patient based on MRI without injecting something into the disc. So it's another aspect of the research that we will develop. The tool in MRI that we are developing will help us for the research, but will probably help the clinical decision for surgery or not, to better characterize disc pathology and to replace discography.
Okay. And then on the MRI, can you see the fissure? That was the goal?
Yes, this is a goal, because with classical sequence that are using in practice, the T1 and T2 weighted sequence. If you are very, very, very lucky, you can see the part of the fissure, but it's very, it's not very well. These sequence are not designed to assess fissure into the disc, so you won't see it properly. So the sequence that we are developing are designed to see this, are designed to see fissure. But now, currently, with sequence used in clinical practice, we don't see them, or we barely see them sometimes, if we are lucky.
Yeah. And then you can move them while they're doing the MRI to see like this dynamic behavior, like how
Now, now this
no.
we for now, because MRI is very sensitive to movement, and if you move in it, for now, if you move in it, you will have lots of artifacts, and the quality of the pictures that you will have will decrease a lot. So this will be in the future when we will progress to test the hypothesis with patients. This will be a question, because should we put the patient in extension or inflection into the MRI, or should we do flexion, put the patient MRI, extension after, and put the patient MRI? This will be a question,
Yeah.
but there won't be but for now, there is in my knowledge, there is no technology that will make us able to move the patient into the MRI while seeing what's happening. It's I don't I'm not no there is no.
Yeah, it's challenging. Yeah, maybe you put in like static position and then keep them that way. Because I don't know. I think if you do like a lot of flexions, but then they are lying down in extension, then
Yeah, this will be this will be the question that we'll need to respond before to do the clinical cohorts.
yeah. Okay. Well, lots of challenges there. It's super cool. I thought like the topic when you sent me the papers, like that's very cool. It just seems really complex, and it's gonna take a little while to evolve on that regard. But it's super interesting. Super interesting. Um, and then also, I know that you're working on pain characterization, right? With like some tech knowledge. Um, would you like to talk about what you've been doing in that area, your research?
Yes, this is the second main topic of my research. So I work with my PhD mentor is a neurosurgeon which is specialized in the treatment of failed back surgery syndrome. So the people who had a surgery, the surgery uh, was not very did not have very good results, and the patient are still in pain with lots of disability. So he is specialized with treating that kind of patient. So to help him on the way he should redo a surgery or not, etc., etc., he developed lots of tools to assess the pain properly. And when I arrived into the research team, I say, "Oh, that kind of tool are really nice, and we could use it also in physiotherapy." So it's what I presented in Ottawa. There is few tools that are very cool, and now we are validating them into for the clinical practice in physiotherapy. So the first one is it's a it's a quantitative pain mapping software. So it's what you're doing when you're doing a body chart. You have the body of the patient, and the patient is drawing on it. So we numerize this. The patient enter his weight and its age and his sex, and the software is able to create an avatar with a silhouette of the patient, and the patient draw on the avatar, and the software is able to calculate several parameters, the pain surface in square centimeter, and the distance of each pixel that the patient is drawing from where are the pixels to the center of the spine. So we have three main information. We have the surface of pain, we have the topography, the distance between the spine and the pain of the patient, and some information regarding intensity too. And this helps us to develop. So this is a very good tool to assess pain evolution from session to session with patient. So it's an outcome measurement, which is more precise than a simple numerical scale. And the second main advantage, it's what we just developed. The paper is accepted now, and we are waiting for the publication. We validate, it's what I presented in Ottawa. We validate an algorithm that is able to detect centralization and directional preference based on the software with patients with spinal pain. So how it works? The patient draw his pain. We do the repeated movement. Then we redraw the pain on the software, and the software is able to say if the patient centralized or not with a confidence interval, so an approximation of the uncertainty. And this uh, help us to. This is very cool to classify patient in an objective way in research. But in clinic, in the next, I think, few years, we will link this software to outcome measurement, and in I think 5 years, 5 to 10 years, I think we would be able to based on the first session, being able to predict the outcome of the three, fourth, five, fifth, sixth session based on the pain variation in the first session. So we are working on this now to better identify patient and predict outcome.
That's super cool. But then, like, let's see if I understood. So instead of like you relying on the subjective report of the patient, so like they say, oh, now my pain, it's not on the knee, it's in the mid thigh, for example. And it went from like, I don't know, 7 to 5 out of 10. So instead of you just getting the information from the patient, you are making in an objective way, putting on the system to see the progress of the patient with like concrete data. Is that what you said?
Exactly. And for now, the software is only able to say centralizer yes or no. But in the future, he would be able to say, okay, if the patient is doing his exercise in a good way, etc., we could expect that kind of outcome in 2 weeks, 3 weeks, 4 weeks, etc.
Mm-hmm. And you say in the future, why? Because they have to like get more data to start like recognizing patterns.
Yes, we need data now. There is few aspects that we need to improve. The first one is to im- to make the software more precise. So we need more data to make the diagnosis more precise first, and then we need to have some prospective data. Patient who 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 record some outcome measurement at 1 week, 2 week, 3 week, etc., to make the software able to predict the results. So it's now it's the steps of collecting data.
Mm-hmm. And who is going to be adding the input to the system? Is the patient that's going to be like looking at the body chart and like, selecting the where is the pain, or and then putting their number, or is that the clinician?
Alors, it's the patient which is drawing, but by experience, he is not able to doing alone. You have to be there to guide him because yeah, it's we tried. I tried to give the software to the patient and say, okay, you draw, and then I check, and it's always it's no. You have to be there to guide the patient. Otherwise, the data are not very good. So we could not replace the clinician on this.
Yes, yeah. Yeah, it's funny because you give them like a scale, the 0 to 10, the pain level. And then if you ask them the function is the opposite. And then they get lost. Like the 0 is like good function, and they have the opposite like rationale. Even if you write down, they don't understand, and they fill out the stuff wrong.
Yeah, and for the when you are drawing on the body chart on the software will calculate the pain surface. So the patient should draw all the surface of pain. If he's only circling or doing a dot or etc., it won't work. You need to to draw on the. So you have to be there to help him. Otherwise, he won't be able to do it properly.
And when you start thinking about that tool, it was the goal to help with research, or to help the clinicians, or then potentially going to help the
Both,
clinicians? Both, yeah.
both. Because in research there is a need, for For the research on directional preference, there is a need for a very more objective way of including patient. Lots it's there is good research on directional preference, but lots of inclusion criteria are very subjective. It's the clinician who decide if the patient has a directional preference or not. We should have a more objective way of including patient, like you have in any medical research. You include a patient, for example, in I don't know which kind of medicine research. You have to have that level of molecule into your blood, etc., etc., etc. We need to have the same objective and systematic approach to have a very homogeneous group in research. So this is a very important part, and I hope the software will help on that aspect. But there is this. But for me, when I'm thinking research, I'm thinking clinics right away. I'm not only a researcher. I have my practice. I see a patient 2 week and a half, 2 days and a half a week, and all the tool I am developing, I have always in mind that how I could use it in practice. And it's so frequent that you have patients who are not able to explain properly how is the pain, how it evolves, etc., etc. Or there is lots of situation in which it's not very clear what the patient is saying to you, etc., etc. If you have a much more objective way of measuring different aspects of pain, it's much easier. And all the data that I collect for the research, I collect in my clinics with patients, and I was surprised several times from what the patient was drawing on the software and the result of the software by comparison of what he was saying to me. And I say, oh, it's not what I understood. And with the software, it's much objective and clear. So with more precise tool, we will have more precise outcome and better outcome. I'm pretty sure. So there is a translation very easily, which could be done from research to practice with that kind of tool.
Mm-hmm. Yeah, because sometimes the subjective report of the patient can be very confusing. Like they think, oh no, it's better, and then like on the next minute they're like, no, it's all sore, and it gets very hard and confusing. So I imagine that would be, yeah.
And with a very objective, it's much more easy.
Mm-hmm. And so how did you develop, or who is developing the algorithm? Like how do you do that?
It's not me. It's the mathematician of the research team. It's honestly, I have the mathematical formula. I don't really understand it, but he had the data. We did to develop the algorithm. We do a two steps process. First, we collect data on 12 or 13 patients, I think. And the mathematician has data from the software and the clinical classification. He developed the algorithm to make a perfect match between the data of the software and the data of the report of the clinician. And then we do a second steps in which we collect data with the software, blinding to the decision of the clinician, and we compare. And it was pretty good. But it's a mathematical formula, and
Yeah, that's not,
it's
no,
it's mathematics.
yeah, it's probably not for the therapist to worry about that part. I was just
Yeah.
curious.
No. Yeah.
And so your plan is to make this available to clinicians. So what are the next steps? Like at some point, you want to, let clinicians use it, or is just for research? What are your plans?
Now the plan is to make this tool available for clinician, but there is lots of steps before. There is some research steps, but there is also legal steps. For example, in Europe, if you want to commercialize that kind of software, it's a medical device. It's considered as a medical device in the European law, and to have and to commercialize the medical device, you need to have some steps to validate, like the FDA approval for in US. It's the same process in Europe, and it's a long process with lots of criteria to, and it's very costly. So now we are reflecting on this. Should we start now or wait that to have more data, etc., etc.? So there is, some aspects and legal research and legal aspects that we need to cover before. But I hope to make that tool available for clinicians as soon as possible.
It's gonna take a minute.
Now, no, it will be long.
Yeah. And now I also know from my interview with Mark Laslet, he mentioned that you were working some papers together, that now you are with another paper under review, right? Uh, do you wanna tell us about that one?
Yes. It's a very good paper. It's the third aspect of my research. It's also in clinics. I have a big interest in how to, like Mark, how to get diagnosis of patients which are in pain, who are in pain, and we have a collaboration with Mark, and we reassess some of his data that he collected during his PhD, and we complete the paper that he published in 2005 on centralization, in which he demonstrates that centralization was very well associated with discogenic pain. He compared the centralization to results of discography, and he had very good results. But centralization is only one aspect of the directional preference. So we complete the analysis with data of directional preference, and we had even better results than with centralization alone. So directional preference is a better tool than centralization to identify discogenic pain in low back pain patient. So the paper is now at his second round of review. I hope it will be published soon. It's depend on the reviewer and all the process. But yes, there is a very good link between directional preference and discogenic pain. As I remember, I think there is 70 or 80 patients, I think, include in that analysis, and there is only one false positive into the whole analysis. So it's now there is a very strong link.
Mm-hmm. That's very interesting. So then now you all have to come back to discuss that paper. That sounds really, really cool.
Yeah. And as I said before the beginning of the podcast, all the research that I'm doing are on a continuum. There is on one side there is a very fundamental science aspects with how to develop MRI to characterize discogenic pain and disc pathology, how to improve MRI, etc., etc. And on the other aspect of the spectrum, there is how could we identify that kind of patient with clinical examination and maybe some innovative tool like the pain software that we develop and all this data all this research will meet at some point.
Mm-hmm. It seems like you are creating a lot of different tools and ways to help research in different ways, because with the mapping, with the pain, you are creating data to help research, right? With the other study, with the MRI, trying to find a more specific way to do research on disc pathology and get that, see what's going on with the biomechanics and how the disc behaves, and and then this other one, how that connects with directional preference and pain. So it's kind of all related, and seems like all trying to give you tools to help with data and research to try to show, to get deeper into the MDT aspect of the things, right?
Yes, and to also bring the basic science support of MDT. We have some pretty cool data on clinical aspects. There is all the work of Wernicke, all the work of Audrey Long, all the work of Laslett that are pretty cool, but mainly based on clinical aspects. And it's where I go back to what my PhD mentor say me at the beginning of my PhD. In medicine, there is not in medical science, because it's not only medicine, but in medical science, there is not only clinical data that are helpful to understand what we are doing and improving treatment for patients. There is also, understand what you are doing on more basic science or fundamental science aspects, in biology, in mechanics, etc., etc. So I'm working on one aspect. It's to develop all that kind of research to support MDT and directional preference based treatment, but more on fundamental aspects, and give support to clinics based on this, and also to make the links between the clinical aspects and the basic research and fundamental aspects of science.
Yes, no, very interesting. Anything else about all these researches and stuff going on that we forgot to mention? Anything that you want to add?
No, it's. I think for now it's good. I will have. I think in 2 or 3 or 4 years I will have new data, so we could redo the
Yeah.
podcast. But for now
Yes,
it's fine.
absolutely. Yeah, come back to tell us how all the projects are going.
Yeah, but as I understand, it's not only to make progress in science. It's not only based on motivation. There is lots of politics and grants and discussion, and it's not only science. So
Not as simple, not as easy.
no.
No. GP, and if people want to learn more about this topic, do you have any resource of information you recommend, or where they can find your papers, or anything that you want to recommend the audience to go take a look?
Okay, alors in French there is a lot. I did a lot of podcasts and web conference and stuff like this. In English, there is yours. I've done one with Mechanical Care Forum with Jason Ward. But I think in English, in podcast, it's just this. There is my paper, otherwise. So two are published in Frontiers, the systematic review and the one on MRI are published in Frontiers in Bioengineering and Biomechanics. So it's open, so it's open access journal, so you can have it. The one on the validation of the centralization algorithm is not yet published, but it will be soon, and it's another open access journal. It's a journal of medical and internet research, and this is the main paper that I have for now. The one with Mark will be if we go on all the review process, it will be in musculoskeletal science and practice, but it's not an open access. And that's it. I don't know if the Ottawa conference is in video or not.
I think they recorded, but it was available just for a little while. I don't think that's still available for people that sign up, right? I don't know if it's open for, yeah.
But in English, that's it. But I can travel easily, so you can invite me anywhere. I can. I come.
See, people, he's, giving you the, telling you the giving you the tips so you can invite him. That's awesome. And any advice that you have for clinicians that are starting their careers?
I think the more precise you are in the way you're measuring stuff, so disability, pain, etc., the better are the outcome. Really, it's sometimes it could be a bit boring to 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 ask for numerical pain scale, to make the body chart properly, to use an ODI or other scale. But the more precise you are, the better are the outcome. Always, from my either from my research and from my practice. And the more difficult are the patient, the more important it is.
Yeah. Yep. And if people want to find you or contact you, is there a way they can connect with you?
You can give them my email address. Sometimes I have lots of emails, so sometimes it could be lost in the flow. So they can write 2 or 3 times. It's okay. I will respond at some point.
Okay, sounds good. And do you have any social media?
No, enfin, I have a LinkedIn profile, but I never go on it. And I think I have an Instagram, but I'm not sure. I should have done this 5 or 6 years ago, but I never go on it. And I'm not very fond of social media, so I'm not so much on them.
Okay, so basically no.
Basically,
Because
no. Yes,
basically
yes.
no. Yes.
Yeah, no.
Okay. Well, thank you so much, GP, for coming here and sharing all your research. And thank you so much for all your work, the work that you've been doing to help the profession. And I think we need a lot of physios that are researchers and clinicians trying to evolve the profession. So thank you so much.
Okay, thank you very much, and thank you to inviting me, and thank you to all people who will listen to me.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening.